We all know as altitude increases, it becomes increasingly difficult to take in oxygen. This can mean a decrease in metabolism to produce ATP, decrease in muscular force output and endurance. So you want to climb Mount Everest? Well, the immediate threat among the obvious avalanches and hypothermia is the lack of oxygen. Even at base camp, there is a significant drop in the available oxygen in the atmosphere. We call this the partial pressure. Right now, we're all roughly at sea level. Here we have an atmospheric pressure of 760 millimeters of mercury, and 21% of this is oxygen in the atmosphere. But how much oxygen is in the air? Well, the partial pressure of oxygen at sea level is calculated through Dalton's law and multiplying standard atmospheric pressure by the percentage of oxygen. 760 millimeters of mercury times 0.21% representing oxygen gives us 160 millimeters of mercury of oxygen in the atmosphere. While the percentage of oxygen in the atmosphere stays the same regardless of altitude, the overall atmospheric pressure significantly drops. At base camp, we see a reduction from 760 to 400.4 millimeters of mercury. So up here, there is our new atmospheric pressure, and it is a lot less dense than usual. We use our same equation as before. 404 millimeters of mercury times 0.21 gives us our new 84.084 millimeters of mercury. We now see the partial pressure of oxygen is almost halved from 160 to 84. This is a huge reduction in oxygen availability for your body, and this will make the commute much more difficult and dangerous. By oxygen content in the blood, we really mean arterial partial pressure of oxygen. At sea level, this is 100 millimeters of mercury. However, under the circumstances that atmospheric pressure is 84 millimeters of mercury, our blood oxygen will be significantly lower. We can see through the following calculations we achieved the ratio of 1.9, and we used this value to calculate the arterial partial pressure of oxygen, coming to a value of 52.63 millimeters of mercury. Based on this, we can determine the hemoglobin saturation at around 85%. While this seems reasonable, keep in mind that normal hemoglobin saturation is at 98%. So from a clinical point of view, this is reaching a dangerous territory. Essentially, we've seen blood oxygen content halved. I think this speaks for itself in how much harder it will become to continue this trek. Keep in mind, we've only been talking about base camp, which has an altitude of 5,000 meters. To get to the top is even more difficult with an altitude of almost 9,000 meters. Peripheral chemoreceptors located in the carotid and aortic bodies detect changes in the arterial blood with a partial pressure of oxygen below 60 millimeters of mercury. Since our arterial partial pressure of oxygen is at 52 millimeters of mercury, these chemoreceptors send signals via afferent sensory neurons to the dorsal respiratory group. This triggers a reflex where we can see increase in ventilation rate. Being at high altitude for more than 2 days can lead to many complications, for example, high altitude pulmonary edema. This condition occurs due to excess fluid in the lungs. The heart is unable to pump efficiently, therefore causing blood flow to congest in the veins, taking the blood to the lungs. Pulmonary edema occurs due to low adequate oxygen supply in the body, which is known as hypoxia. Hypoxia leads to an uneven vasoconstriction of the pulmonary arteries, increasing the capillary pressure. This increased capillary pressure causes stress on the capillary endothelium, increasing its permeability to an edema. Alveolar flooding is increased as there is a decrease in the alveolar fluid reabsorption. We will now take you through the physiological mechanisms of HAPE. So here we can see at sea level there is a healthy lung which has homogeneous blood flow through the pulmonary vasculature. The second diagram shows hypoxia at altitude causes hypoxic vasoconstriction in small pulmonary arteries throughout the lung. HPV moves blood away from areas of the lung that are not well oxygenated, conserving pulmonary blood flow and maintaining a good match between ventilation and blood flow. Vasoconstriction is a normal physiological mechanism in the lung at less extreme altitude. The third diagram here depicts areas of less vasoconstriction, attempting to handle higher volumes of blood, which raises pressure in the pulmonary capillaries and places excess stress on the blood-gas barrier of the lung. This stress can lead to a tear, creating a high permeability edema in the alveoli. Even a slight buildup of fluid in the capillaries impedes oxygen transport and contributes to a widespread and more severe HPV response. Sympathetic stimulation from exercise and circulating vasoconstrictors from prolonged HPV response can cause venoconstriction. This further increases pulmonary hypertension. Tissue damage caused by mechanical stress initiates an immune response and higher capillary permeability. The domino effect results in the overt symptoms of HAPE. Finally, areas of less vasoconstriction attempt to handle higher volumes of blood, which raises pressure in the pulmonary capillaries and places excess stress on the blood-gas barrier of the lung. This stress can lead to a tear, creating a high permeability edema in the alveoli. Symptoms of HAPE include decreased exercise tolerance, having a cough, orthopnea, cyanotic nails, and pink sputum. Immediately descending from the mountain will assist in the treatment of pulmonary. In addition, supplementary oxygen can be taken to assist in reducing pulmonary artery pressure. Nifedipine can also be taken, which acts as a pulmonary vasodilator. However, it should also be noted that there are various adverse effects, including an increase in heart rate, peripheral edema, and the possibility of developing hypertension.